Hello and welcome to today's episode of the Pediatric Consult. I'm Dr. Jill Schaffeld, your host for today. I'm a pediatrician in the Cincinnati area, and I'm excited for today's discussion. With me in the studio today is a familiar friend and returning guest to our show, Dr. Bob Frenck, who is here to give us an update on some recent movement in pediatric vaccines. Lots of exciting things to talk about today. Most of us know Dr. Frenck from all his work during the pandemic and keeping us up to date on COVID-19 vaccine rollout. But for those of you who don't know Dr. Frenck or haven't listened to our previous fall podcast with him, could you share just a little bit about your work at Cincinnati Children's and maybe how long you've been practicing and some special interests, please?
Sure. I've probably been practicing longer than you've been alive, so actually I just had my 42nd year graduation from medical school. So I've been.
I still have you by a little.
Oh, okay.
Thank you.
But I've been here at Cincinnati Children's for 17 years. I'm a professor of pediatrics in the Division of Infectious Diseases, and I also run our Center for Vaccine Research.
Wonderful. So we will jump right in. We have a few topics to discuss today. Lots of movement on the pediatric vaccine and viral treatment front. When we spoke last fall, I believe, we talked a lot about just changes in new vaccine rollout for Prevnar, specifically Prevnar 13, which is now given, to potentially Prevnar 15, and now we have new, which is Prevnar 20. If you wouldn't mind just giving a little bit of a update on kind of differences, and I know we've shared with each other some of your thoughts on the Prevnar 20 vaccine.
So, like I said, I've been doing pediatrics for over 40 years, and I can tell you when I first started, we didn't have any of these vaccines, and so routinely every year we would see a lot of invasive pneumococcal disease, of pneumonia, bloodstream infections, joint infections, meningitis, very serious diseases that we hardly ever see anymore because of the vaccines, and so the original PCV7, which is the vaccine that was first licensed for pneumococcus, did a true efficacy study, so you could see how many cases of pneumococcus were prevented by the vaccination because there were enough cases that you could actually show prevention. After that, all of our other studies have actually been serological correlates to be able to say that you're getting an antibody response that should be sufficient to decrease the pneumococcal disease because even the original PCV7 decreased the vaccine preventable illnesses so much that we really couldn't do a true efficacy study after that.
Which is a good thing, I guess.
Which is a good thing. That's a great thing. And, it's the same thing we've seen with Hib and that so that diseases that were common that we now actually have to go find residents to show them the disease because it's so infrequent. So that's a tremendous thing and how effective the vaccines have been. But so we're now with the PCV13, the invasive disease has been decreased by 95%. So we're seeing 5% of what we used to see. By adding into the 15-valent, so a couple more valents, it decreased by another maybe 1%, and then up to the 20-valent, maybe a little bit more net. So the biggest thing I see the difference of adding the additional valences is now we have two companies that are providing vaccine. That gives us a more stable supply because it's always a concern if you have one manufacturer. If something happens, you lose your vaccine. The other thing is competition is good, that it will then make a fair market price, and that hopefully we'll see that in the offices that the prices will be a little bit lower.
I appreciate that. I don't think it's something our medical brains are always trained to think about, that maybe this isn't a huge difference in kind of, coverage for the different strains of the vaccines, or huge impact on serious disease. But like you said, there's the business aspect of things for supply and demand and driving down prices. And like you said, if something I think we mentioned on our last podcast when we talked about this, I talked about formula shortage and, you get one plant that just makes everything and something happens and it's done versus now we've got multiple options.
Right.
Which is great.
And that's, we've actually seen that happen with flu vaccine in the past is where we've lost flu vaccine because of a manufacturer and plant went down. So that's, I think, the biggest benefit. And like I say, I think the other thing is that practitioners may see the added benefit is the companies may be looking at bundling and things like that to be able to add more competitive prices. So I know it's always a squeeze, and we really appreciate pediatricians sticking with vaccination because I know it's an extra load. It's a financial burden that you're doing as a general pediatrician to have all these vaccines in your office. So I really appreciate you being there for the kids to make sure they're getting what they need.
Thank you. And you for helping develop these as well, and researching them. So moving along to monovalent COVID vaccines, which from the latest I've heard, and you'll have much more info than I will about this, but that we expect out soon, probably within the next 6 to 8 weeks, maybe. And I guess my biggest question in sitting in the office and discussing at, checkups with parents, what are the current recommendations for COVID boosters? So right now, just the bivalent is what we have out for infants and children. And, parents are asking, because we're seeing some uptick in some COVID cases, do we wait? Do we wait for that monovalent to come out? Do we give the bivalent now? And if we choose to give the bivalent now, does that affect when the monovalent comes out, whether or not I can get my child vaccinated? So very, very loaded question there.
Yeah. No, those are great questions, though, and that see if I can disentangle them a little bit on things.
Thank you.
So, in the first place is that there is going to be a monovalent vaccine that's going to be coming out, and I agree with you. It's probably going to be in September, maybe October, but I think they're really pushing hard to get it out in September. It's going to be against the variant that's out now. It's called X11B, I think it is. And so that we've run through all the Greek alphabet, so now we're having to go to other letters. And one of the things I think, is that for people to remember is that COVID, like flu, is an RNA virus. And because of that, it likes to mutate. And every time it mutates, it means our vaccine may not be as effective. And that's why we're updating the vaccine. So because we've had a lot of changes, what the CDC is now saying to be up to date is to, if you've been vaccinated before, is to have one dose of the updated vaccine. And that the updated vaccine will be a monovalent, so just against the one type. The bivalent was the original, if you will, vanilla COVID vaccine, and then had the Omicron variant added in. The Omicron variant has modified a bit to this X11B, and so that the new variant is really an offshoot of Omicron. And so that will be available. It's going to be basically what's called a strain change, and that's what the FDA looks at as far as for flu vaccines. That's why we don't do a clinical trial each year, is because it's the same process. You're just switching out one strain for another, and so it's called a strain change. I think one of the things to me is that if people were asking me when would I give the updated booster, I would wait for it. And so between now and 6 weeks of getting a bivalent vaccine or waiting 6 weeks and get one dose, I would get one dose. I mean, don't stick the kids twice for the things.
Sure.
But the things that I would go back further, 1 second on things, is that to me is that, and I'll get on the soapbox a little bit, but if you look at, we published an article a couple years ago looking at the vaccine-preventable viral infections and the morbidity and mortality associated with each of those, that COVID outstrips every one of them. Is that in a bad year, we have typically 150 to 200 kids that die of flu. I mean, that's horrible. But we've had 600 to 700 kids a year for the last 3 years. So we're over 2,000 children that have died from COVID. And so the hospitalizations associated with COVID outstrip everything except rotavirus. And that now, luckily, with the rotavirus vaccine has been so effective, the rotavirus hospitalizations are way down. I mean, our hospitals used to be full with kids every year with diarrhea and dehydration from rotavirus, which is gone because of the vaccine. But while we've had close to 75% of kids over 12 have had a vaccine, and about 50% of the kids between 5 and 11 have had a vaccine, we're still in single digits, under 5. Single digits. And it makes no sense to me as far as that when at the next highest disease is flu is 1/3 the number of deaths we've had. And every one of these other vaccines was like, yes, these are important. Yes, this is important. Yes, it's important. And to me what this says is that unfortunately COVID has transcended medicine and has transcended public health and has become a political issue instead of a medical issue. COVID's an infection, and it doesn't care who you are or what you believe in or what color your skin is. It just wants a nose to be able to infect. And the vaccines have been incredibly effective to prevent disease and hospitalizations and death. And so while a question is a good question about what would you recommend to parents about getting a dose now versus in 6 weeks, the more important thing is to say COVID vaccines are important. COVID vaccines save lives. And if you ask me about the individual child, if you say compared to me, if I at 68 get COVID, my risk of death from COVID is much higher than the risk of a 5-year-old getting COVID and dying. There's no doubt about that. However, the risk of hospitalization and death in children 6 months to 5 years of age is not zero from COVID. We know it's not zero. And so, we have a very good way to protect against the infection. So that'd be my plea as far as that. I know you guys have been beaten up in the offices. You don't even want to talk about COVID vaccines anymore because it's become such a hot button. But if you can stick in there and try to be, putting out there about why vaccines are so important and why COVID vaccines are important, you're actually doing your patients a big favor.
Yeah. I remember, and this is kind of going back to just immunology in medical school, but I had a colleague that once explained it to me that when COVID first started, COVID was truly, that virus was a true antigenic shift. Mm-hmm. Like back in the 1920s with the flu pandemic, as opposed to influenza, which every year there's a slight drift, right? Changes in the strains like we're talking about. And it seems like we're getting there with COVID. It's still killing many more people, as you mentioned, but we're now to the point where, yes, there's going to be a little bit of drift, but you also have that immune memory from having those vaccines over and over again. So you get the virus, and even if it's not the newest strain that's preventing, your immune system says, hey, I've seen this before. Exactly. I've seen something super similar, and it's much more effective.
Yes.
So I think I agree. We really need to get back on the, there was so much excitement for the COVID vaccines initially for primary care physicians, but I also think just the importance of the vaccine in general, whether it be the bivalent that someone's sitting in the office and wants to get, or they want to wait for the monovalent, just yes. And
Vaccinate.
Yes, you need it. And yes, it's very important.
Yes.
Absolutely.
And it's still important.
Wonderful. And before I move on to a very hot topic, just one more little update. Do you anticipate a combo influenza COVID vaccine next season in maybe 2024?
I would think that would be the soonest. I mean, that they have a couple of companies have been working on an mRNA flu vaccine. So one of the things you'd have to have be the same kind of platform. And so that they now have data on an mRNA flu, and it's been looking pretty good. So I think it's a possibility in the not too distant future of having a combined vaccination, because anything we can do to decrease the number of vaccinations would be good.
Absolutely. Well, we are going to dive right in now to a little bit of a different, and I'll let you can kind of give your opinion and your insider kind of info on the RSV monoclonal antibody, which is not technically a vaccine, correct? It's a monoclonal antibody. And this is really hot off the press. I think August 3rd, I believe, was the true approval. And now I'm trying to remember whether that was FDA approval or that was actually the ACIP. I think that was the ACIP recommendation for the new RSV monoclonal antibody, Nirsevimab, I believe.
There you go. Good job.
Yeah, well, it's brand new, right? So first, if you could just take us a little bit through kind of how does the antibody work, and then what would be the clinical implications of that.
So Nirsevimab is, as you're saying, a monoclonal antibody. So it's passive immunity. It's not a vaccine, so that it's not going to give you long-term immunity. It's in a lot of respect very similar to palivizumab. The difference between palivizumab and Nirsevimab, though, is that palivizumab never was able to be shown to decrease mortality, and it really was weak as far as even decreasing hospitalization. But with the Nirsevimab, what they did is that they took kids that were not eligible for palivizumab because they were older, they were outside the recommendations for palivizumab, and they give them the Nirsevimab. And what they showed in the group so they were the well group, that you decreased medically attended visits, you decreased hospitalizations, you decreased ICU visits. There were two very well done New England Journal papers looking at that. So this is really the biggest difference between Nirsevimab and palivizumab, is that and it's one of the things that I think is going to be a big shift, because, you're talking about drift or shift is a big shift here, is that we've been telling pediatricians for years and years and years, palivizumab, it's a very select population, and that no, don't give it outside of that. the recommendations for Nirsevimab is going to be for every child.
Absolutely.
And so it's going to be a big change. But the reason that change was made is because the data showed that you could decrease the medically attended visits, you could decrease the hospitalizations with Nirsevimab, which you couldn't with the palivizumab. The great thing about the Nirsevimab is one dose, and versus the Pali, which is one a month for 5 months, and that
total.
So
Yeah.
it's and the other thing too is that what the from a marketing standpoint, what the sponsors or the industry makers were looking at is to try to make it that would be competitive with a dose of a vaccine versus palivizumab. So palivizumab is quite expensive, and but the Nirsevimab, they're trying to make it more in the line of like a pneumococcal conjugate vaccine. I'm not sure the exact price, but that was what the target is. And part of the other thing too is that you may hear people use the word vaccine instead of monoclonal antibody, and part of that was because the sponsor wanted to get this approved as a vaccine because then it'd be covered for the vaccine for children or VFC. The good news is that the FDA was able to do a little bit of wrangling, and and it is qualifying for VFC.
Wonderful. I think just the equity there is
Yes.
such an important thing
Yes.
to talk about. And that kind of ties into what we were talking about with Prevnar in terms of what you were saying. My initial months ago is Nirsevimab. Okay, well, we have palivizumab, right? Except for, like you said, 5 doses. Very expensive. Obviously, 5 doses because it doesn't last as long. I mean, this is a game changer for supply and demand and makes perfect sense why now it is available just cost-wise and the ease of use and availability of supply and doses. And
Right. So a lot of it too, though, is it is that one dose, which is great. But the reason that it was recommended for every child was because of the ability to show the decrease in medically attended visits, the decrease in ED visits, the decrease in hospitalizations that palivizumab never could show.
That's
and these are in healthy kids. So again, make it clear is that we're not talking about the studies being done in children with chronic lung disease or chronic heart disease. These were studies in otherwise well children that were then given the Nirsevimab. So it's a population that is getting RSV outside of the range of what you're considering high risk. That's the one that they looked at, and that's the group that they showed that there was a decreased medically attended visits, decreased ED visits, decreased hospitalization. So that's really the reason as far as the global recommendation, because they could show that it was really effective of doing all those things.
Yeah. I don't have breakdown of, high risk versus non-high risk, and I think we as community pediatricians understand the importance of, protection against RSV and the medical significance of the virus. But the numbers I had seen just in kind of preparing for this talk was 58,000 to 80,000 children and infants under age 5 hospitalized per year per RSV season, and then somewhere between 100 to 300 deaths per year from RSV. So very, very significant when you think about it in that way.
I mean, it's in some respects, it's kind of like when we were doing hepatitis B vaccination for moms. In the first place, it was a selective immunization for mothers that were at high risk. And it is very effective of preventing hepatitis B. However, what we found is that mothers at high risk, so that they were hepatitis B surface antigen, if those are the only mothers that were targeted, you missed most of the moms. And so if your high risk has a population, say 10% transmission, but it's only 1% of the population, and you have 99%, and you have a 1% transmission, you have far more transmission in the low-risk group. That's a similar kind of thing with the RSV, is that the non-high risk, so the kids without underlying illness, are the vast majority of the population.
Absolutely.
And so that even though they have a lower overall risk per child of getting RSV, when you take that giant population and multiply it even by that smaller percentage, the outcome is many more cases that have no underlying illness.
Yeah, very impactful for sure. So just moving along to some of the current recommendations for Nirsevimab. All infants under 8 months of age born during RSV season, which then you get the grayness of medicine, right? So fall to spring. And I think in this area will be October to March. Does that sound correct? Okay.
Yes.
And then I know there is some wiggle room just for community rates and things like that in terms of recommendations.
Yeah, so that where it's going to be the tricky part is that if you have a baby that's born in April, or May or June or July, August, and so the ask there is going to be to keep a registry, and then you call them back in October or November to be giving them their dose then. If they're born during the RSV season, the goal is to give them the dose of Nirsevimab before they ever go home.
Great.
So that it's done as part, and the goal again is to try to bundle that with the package, the insurance package with the pregnancy, and it just like the hepatitis B vaccine, is that you're giving the Nirsevimab as part of that bundle.
And you do anticipate that being more a nursery-driven thing?
Yes.
Before
Yes.
Okay.
Yes.
Because I know definitely the recommendations are within the first week of life, and often we see them in the office in that 5 to 7 day range, which obviously we'd be able to catch some maybe that didn't get it in the hospital, but I think that makes the most sense for making sure that everyone gets.
And that's why it was said in the first
antibody.
week, is because it's really trying to target before they go home from the hospital. But let's say somebody goes home and they didn't get it within the first week. That's just a recommendation. It's still going to work fine. And so if somebody comes in and a kid's 3 weeks old or a month old, they still qualify. So they still be fine to get it. And so that you're going to have the group of kids that are born between October and February, maybe, as far as that you would give it to them that year. After that, you would be, March through September, something, like I say, keeping a registry, then bringing them back in as practical, because you're not going to be able to give all those kids a vaccine in a day or something like that,
Sure.
or maybe the monoclonal in a day. So you'll have to kind of figure out how to schedule for that. And then the other thing is going to be kind of interesting as far as with the second year. They're still talking about doses for the second year, and that right now at least is more toward the high-risk kids.
Sure. And I was looking at some of those categories of high risk for the second year dose. So obviously any immunocompromised, chronic lung disease, anyone requiring oxygen, cystic fibrosis, things like that. The two, I guess, things just to mention that surprised me a little bit. Weight for length less than 10th percentile. I thought that was an interesting. I don't know if that was one you had seen as
No,
as
but
listed as high
I think
risk.
it's probably just that they're maybe a little bit small, and
Sure.
that and so that a little
Nutrition
bit.
and / nourishment, and yeah, absolutely. And then American Indian and Alaska Native as well. We're kind of lumped in that group. So
And that's just because, from epidemiological standpoints, that they have a higher risk of having severe disease than other backgrounds.
great. Good to know for sure. Interesting, when we talked about just thinking as you have been, but as this is more recent for primary care providers in the office setting, just trying to think, as you're talking, think what will our office flow be? Like you said, is it, we're going to have to and we're going to have to think about those things. Do we say, April 1st, or, we write any baby under whatever, age and bring them back. So just a lot of differences kind of in how the process will occur in the offices for this one.
There's going to be some, bumps in the road, but that, and hopefully that the product will be available fairly soon. The manufacturer has said that they have a big supply, so that, I think they're counting on trying to get it out to the market this fall. But if you were in a situation where you have a child that would qualify for Palivizumab and you don't have the Nirsevimab, please give them the Palivizumab, so that don't get rid of the Palivizumab yet. And that, but if you have somebody that's and you have the Nirsevimab, I would recommend switching over to that as soon as you have it.
Sure. I think just for ease of administration makes perfect sense, and for even family compliance, because the Palivizumab with the 5 doses is quite a bit to keep up with. And I'm glad you brought that up, because it was something I did want to touch on, which you did, which is if, Nirsevimab is not available, to go ahead and give the Palivizumab. But I think the other one I wanted to touch on was if Palivizumab was administered initially, but less than 5 doses were given, also it's indicated to give the Nirsevimab at that as well. So great. That's wonderful. And lots of good information there. So a little bit of switch of gears here. I believe in May, and you'll be able to correct me if I'm wrong on this, there was also a RSV vaccine for adults approved, and maybe it might be a monoclonal antibody. It is
It's
a
a
true
vaccine.
vaccine. I haven't yet seen any data or any recommendations if a pregnant mother received that vaccine. would there still be a recommendation to go ahead and give Nirsevimab?
So this is
only I get to see your face during these podcasts.
No, that's an excellent question that a lot of us have been asking. And so to answer your question is that there is a vaccine. There's two groups of where it's been looked at right now. One is in pregnant women, and the other is in I'll call it mature adults, and that has because there is a concern as people age that there's an increased risk of RSV disease. So, but for the pediatric centric is really as far as for pregnant women. And that the sponsor was, again, a very well-done study. A big number of women were followed. And what they did is that after they gave the vaccination, then they followed the babies through the first 6 months of life and to look at, again, the number of ED visits, hospitalizations, and that the vaccinating mom they tried to get it more toward the third trimester, so second to third trimester, had decrease of 83% of medically attended visits within the first 6 months. So it worked very well.
That's impressive, yes.
And so but your question is an excellent one as far as, and one we don't have the data for yet, as far as what do you do? Is it if a mom was given the vaccine? I think until we have data, otherwise there's nothing that we know that it would hurt a baby to give the Nirsevimab. So my guess is we don't have data. And so my guess is the recommendation is going to be is that babies get Nirsevimab, and that there are a number of RSV vaccines that are being tested in children, and so then it's going to be who gets the vaccine, who gets a monoclonal. So there's a lot of research questions out there that still need to be answered.
So lots coming on that in the near future. But yeah, sitting here in my pediatrician brain, I'm going, well, it's just extra immunity, right? But yes, definitely need to make sure that there is at least some sort of a recommendation, hopefully coming on that as well. So we'll definitely look out for that. So just kind of moving along, is there anything that we should worry about safety-wise? Any side effects that we can tell when we're vaccinating these children in the office? So one thing to mention, which I'm sure everyone listening probably understands, but that this is safe to be co-administered with any other vaccine, like childhood vaccine that would be given, which gives us a lot of leeway to be able to give it at any visit, which is wonderful. But I know parents are going to go,
you're talking about the Nirsevimab now.
Correct.
Okay.
Yes,
okay.
Thank you. I did completely switch gears. Parents are going to say, well, what's the side effects? What should we expect to see in our infants that have had this?
So that Nirsevimab is the monoclonal antibody, and so the adverse events you'd be expecting would be the similar of giving gamma globulin or giving palivizumab, and that most of it's going to be you're giving a shot, so that it's going to hurt. There may be some redness or swelling of the site, but actually the side effects otherwise have been very minimal. It's been very safe. And so that if you look at all the data and to be, like I said, totally upfront about things, in the study, there were 6 children that died, but when they very closely adjudicated those 6 cases, and none of them they could find that had any association with being in the study. I mean, it was horrible that those children died, but that all of them had alternative causes that were the reason for the death, and not
were pretty easily identified.
Yes.
Yes. So yeah, I mean, that's part of just real life data, right?
Yes.
So, which
unfortunate,
like you said.
I mean, that's the thing as far as that with COVID vaccines and stuff like that. People say, well, somebody got a COVID vaccine and got a heart attack, but then people get heart attacks, and so that's why it's so important to do clinical trials so rigorously, to collect your data rigorously, so that you can look at what's your rate of a side effect in the group that got a vaccine versus a placebo. And that's, when people ask, why do you give placebos? That's one of the reasons you give a placebo, so that you can see what the rate of a side effect is in the placebo group. Because if it's the same, then it's not the study agent that did it. It just happens.
Makes sense. I know you had mentioned, and I'm switching gears a little bit again on more kind of just practical questions, and even for offices as well, as we look forward to this coming out in the fall. You mentioned vaccine for children and that the ACIP was able to kind of find a way to hopefully have that covered for vaccines for children. Private insurance is coverage at this point. Do we expect it to be good? No
I don't think
problems, no
I don't
issues at all?
expect any issue there, no.
That's an easy, quick answer, and I like it. So, because I know that'll probably also come up as we counsel our parents for this as well. So, well, great. Is there any other things that maybe we didn't talk about in terms of the Nirsevimab that you can think of that you want to share? I think this is a very timely subject. It's been wonderful to learn about.
No, I mean, to me, this is a very exciting breakthrough. I mean, it isn't just like a lot of times when we'll get a new product, it's kind of like it's a me too. You know, like you had amoxicillin and you get this other cephalosporin. It's kind of like, you can use this too. But the Nirsevimab versus the Palivizumab really is a huge difference, and that because it does offer such broad protection and has been so successful in decreasing the medically attended visits, the ED visits, the hospitalizations, so that, my hope would be this is going to be something that's going to look just like the rotavirus, where we used to have kids in the hospital all the time. We don't see that anymore. That would be a similar thing as I'm hoping with the RSV.
It is a little wild to think, but and you shared, obviously you have much more experience and many more years practicing than I do, but lots more knowledge for that reason as well. But, this is probably the first big change to what I would call kind of the infant and childhood vaccination schedule that I've seen, other than just small tweaks like we talked about, Prevnar 7 to 13 to 20. This is brand new, and so really exciting. I think it's hard, and our colleagues that are listening will know this, but it's hard for maybe people who are non-medical to realize what a big deal this is. I mean,
it's a big deal.
Really changes things.
And that, it could be actually then general pediatricians can have time to breathe during the winter because they're not getting slammed with every acute gastroenteritis and every upper respiratory tract infection. We may be able to prevent a lot of those.
Definitely. Well, I want to thank you for everything today. This has been wonderful. I think a lot of good learning points, and looking forward to hopefully some exciting fall administration of
exactly. And then hopefully, next year is that if I come back, if you have me back, is that to be able to give you some answers to the question of what do we do if mother's been vaccinated about the monoclonal for the babies.
Yeah, definitely. Well, thank you, Dr. Frenck. We appreciate your time and all your knowledge that you share with us, and it's been a pleasure.
It's my pleasure. Thank you.